my career, figuring out what's meaningful for people, especially seriously ill people and people at the end of life, is a crucial and very neglected part of palliative care. So this is a very meaningful talk for us, and we're working on the contextualization of palliative care, not only in China, but in all the sites where we work, including in Africa and the Americas. But China is so big a part of the world, and there's such a large Chinese diaspora. So I think this topic is extremely important for us. Thank you.
Wonderful. Eric, it's exactly 2:30.
Okay.
We can give folks a few seconds to gather. We can get started with introductions. It's up to you.
So, Professor Jun, I'd like you to meet Dr. Hadi Khan, who organizes, who's our director of our lecture series, and we rely on her for so many things, and I hope that the two of you will be able to meet sometime. Dr. Hadi is a member of our Global Palliative Care team and in charge of our work in Africa.
Okay.
Nice to meet you virtually.
Thank you, Hadi. Nice to meet you too.
Okay, so right now I'm alone, so I'm going to take off my mask. I may need to put it on again. But for now, I don't need it. And Hadi, we'll start whenever you say.
I think we can, it's about 2:32. We can give it maybe just one more minute
Okay.
for folks to gather. And then
And you'll give the first words, and then I'll introduce Professor Jun. Is that the plan?
sure, I'm happy to.
Thank you. One of these years, I'd like to be in China during the New Year celebration. At least one time, I'd like to do that.
You haven't done it.
No,
Oh.
I was once during New Year's in Vietnam, and it was wonderful. It was very, very cold where I was, and the homes have no heating. So we all sat on the floor with my friend's extended family, probably about 40 people of all ages, and with food spread out everywhere, all kinds of special New Year's food, and it was great.
Wonderful. On that note, I think we can get started and we'll be able to introduce the session, do a little bit of housekeeping while the rest of our friends and colleagues join us. Good afternoon, everyone. My name is Hadi Khan. I'm one of the palliative care physicians and internal medicine physicians here at Massachusetts General Hospital and faculty at Harvard Medical School. On behalf of all of my colleagues in the program of Global Palliative Care within the Department of Global Health and Social Medicine at Harvard Medical School, I would like to welcome you to our Palliative Care Lecture Series. As many of you might know, this platform is really dedicated to discussing topics related to the development of palliative care, especially in low and middle income countries, including discussing topics related to education, research, program building, policy making, and contextualization within the field. Our featured speakers have been and will continue to be renowned palliative care practitioners, educators, innovators, researchers, as well as numerous of our regional partners who are doing innovative and foundational scholarly work in the important field of palliative care. Today, we are delighted to welcome Professor Jing Jun from Tsinghua University in Beijing, China, And we are grateful for him to join us at this very, very difficult hour. It's about 3 o'clock in the morning in China, I believe. But in the spirit of generosity and sharing knowledge and scholarly work, we really are honored that you could make time for us today. And without further ado, I'll turn it over to Dr. Eric Krakauer, Program Director, to introduce our speaker.
Thank you, Dr. Khan. Thanks so much. I'm Eric Krakauer. I'm also a palliative care physician at Massachusetts General Hospital, and I direct the program in global palliative care at Harvard Medical School. And I'm particularly thrilled to have Professor Jing Jun speaking in our first year of our Global Palliative Care Lecture Series. And again, as Dr. Khan said, I'm so grateful that he's joining us at about 3:30 in the morning, Chinese time. He's in Beijing, and a few days before the New Year celebration, which is the biggest celebration of the year. So it's very generous. Professor Jing Jun is professor of social anthropology and director of the Public Health Research Center in the Department of Sociology at Tsinghua University. And MIT is like the Tsinghua of the US. It's the top technical, Tsinghua is the top technical university of China. After finishing his PhD in social anthropology at Harvard University in 1994, he taught at the City University of New York for 6 years before returning to China and to Tsinghua's Department of Sociology. His books have included a study on collective memory of suffering, which is in Stanford University Press, and an exploration of social theories for public health, published by the Chinese Social Science Press. He also, his academic work also includes studies of the impact of HIV in China, and more recently, a study of 7 Buddhist nursing homes and of issues of death and dying among cancer patients in Chinese hospitals. This research also includes interviewing family caregivers and medical professionals around China on end-of-life care. Today, the topic is, I think, extremely important and much neglected. Here at the program in global palliative care at Harvard Medical School, we're very interested in the contextualizing of palliative care. That is to say that because beliefs and traditions related to health and illness and life and death and suffering vary from culture to culture, and also the spectrum of diseases varies from place to place. Palliative care needs to be contextualized. How we practice it in Boston may not be appropriate for Malawi or China. It needs to be tailored to the local culture, the local language, and of course to the individual patient. And what makes life and death meaningful may vary from place to place. So Professor Jun has, through his work, has become an expert on what makes life meaningful at the end of life, and what might a meaningful death be for people in China. So we're very grateful to hear from you, and we think that this is important work, not only to optimize palliative care in China, but to help us figure out how to contextualize palliative care around the world. So thank you again for joining us. Professor Jun, please.
Thank you, Eric, and thank you, Kathy, and thank you everyone for coming and to hear my discussion, to join this discussion. It's very early in the morning. I slept for a little while, and then I took a shower and go on, and now I'm online. I want to say something about the background of today's discussion. About 5 years ago, Arthur Kleinman at Harvard Medical School started a program called Social Technology for Seniors in China and Globally. And one of the research topics I choose by joining him and his team. And so I choose was death, death and dying. So we worked on several, we did several studies since in the last 5 years. And today I would like to say something about essentially about palliative care as practiced in hospitals. So let's start with some background. So when it comes to dying and death in China, and the most probably reliable data statistic coming from 2019, because of the data were messed up in the last 3 years because of the COVID. And so that year, about 20% of those who died did so in hospitals. And that means the final death, not the dying period. A lot of people stayed in hospitals in the process of death. And of the urban residents, 23% died in hospitals, while you can see there is a rural-urban difference. 19% of rural residents did so in hospitals. So essentially, we're talking about in the country, 80% of the population eventually died home. So hospital is still not yet the final place for most people. And very few people, very small proportion of people die in nursing homes. Essentially, in Chinese nursing homes, when people are about to die, they send them to hospitals or they send them back home. So home is the place of the final rest place. But I should also mention, Eric just said we did a study of 7 Buddhist monasteries. And in the process, we find out that actually now, 2 years ago, there were 50 Buddhist monasteries practicing end-of-life care, but now there are about 70 of them. And there are hundreds and hundreds of Christian organizations quietly providing palliative care, end-of-life care across China. But if we look at some of the figures, city by city or area specific, we realize that there is a strong association between social status and place of death. And in the city of Hangzhou, 70% of the urban residents die in hospitals. And I mean, the people who received college education. So, and in the city of Chengdu, the population is divided into rural and urban, and the urban population about 60% die in hospitals, and the rural about 30%. And according to a Chinese CDC report a few years ago, Chinese government officials are most likely to die in hospitals. And this is because their medical insurance covers 100% of their hospitalization and outpatient and inpatient bills and outpatient bills. For myself, I want to share my medical insurance plan covers only 85% of in-hospital bills and 75% of my outpatient bills. So you can see medical insurance has something to do with dying in hospitals. And the Chinese government officials are most likely among all kinds of social groups to die in hospitals. And the second item of business I want to take care of is about terminology and timeline. And this is important because when we talk about palliative care, when we talk about end-of-life care, what do we mean and now, and what did people mean historically? So very early on in Chinese history, the concept of proper death, and we call and in the name of Shanzhong, was developed. The concept was already developed about 200 BC, and in several Han Dynasty documents, and essentially refers to 3 things. First of all, people do not die of a violent or sudden death. So people die natural death, and then it's proper death. And then secondly, it's the Confucian school of thoughts defined proper death as proper rites, like proper funeral rites and proper burial rites and proper burial itself. And there were legalist philosophers who defined proper death as no shame, And historians around that time, like Sima Qian, defined proper death as death in glory, as death still working as a top-ranking official. So that's the first term. And the second term around the 7th century, when Xuanzang went to India and brought back thousands and thousands of Buddhist books, he started to translate this Buddhist text from Sanskrit, and he encountered the term nirvana, and he translated into Chinese as yuanji. And so yuanji contains the meaning of moral fulfillment. In other words, dying with moral fulfillment, dying calmly, be ready to death. I mean, this concept was yuanji. So it's and then in around 900 AD, and when novels first started to become quite popular, and in the popular novels, good death was mentioned, especially since the printing technology was invented in the Song Dynasty, so people could read novels, and the good death was, another meaning was added: not cursed, natural, but also the family line is intact. In other words, if one's family line is broken and the person dies, and it's not a good death. So that's the third term. And then one term I particularly like is borrowed from Buddhism. It's called enlightened death, 自在圆寂, and that is using one's wisdom and one's moral integrity to be prepared, to be calm and ready to die, and even knowing the approach of death. So these are older categories of concept about good death. There are new ones. And if we look at the timeline of the new ones, in the 60s, 1960s, we already have the concept, the concept of palliative treatment. Palliative treatment was already in the Chinese medical journals, and it's called 姑息治疗. It was meant to appease, to give comfort, and to control pain. That was called 姑息治疗. And end-of-life care was introduced by overseas Chinese into China in the 80s. So the first palliative care center was set up in Tianjin at the end of the 1980s. And then in the past 20 years, the concept of death with dignity was introduced into China from the United States. It means good death, personal, and especially emphasizing personal autonomy, one's own choice. And then palliative medicine, non-aggressive, less painful, was very much picked up in the literature, in the Chinese literature. And finally, in the last 7 years, we have palliative care as a term now dominating the literature, the medical literature and the social science literature about terminal stage of care, comfort, but emphasizing professional practice. Not palliative care is not something you can give at home. That's what they define. And palliative care is not something you use for other purposes, but only for terminal illness. These have problems, of course, but as we go along, we'll see why. And today I want to deal with essentially, 4 issues that in the last 5 years we have been talking about with my colleagues in China. And that is, the first one is social ecology of healthcare and death with dignity, awareness of dying, and legal rational approach. The background is quite simple. The data we're using today for my talk is 2 rounds of survey in 14 provinces, and students from a medical school working with me, they interviewed, they surveyed more than 100 family caretakers of cancer patients who already died, and died in the last 3 years when they were interviewed. And 2 rounds of interviews about personal stories of taking care of the terminally ill. And in this interview, we interviewed more than 200 family caregivers. So these are the essential. I mean, this form the basis of my talk today. So let's look at the first issue we have been interested in, and meaning referring to the what we term called social ecology of healthcare. Essentially, ecology of healthcare was developed in the 60s in the United States. But when we look at this concept, ecology of healthcare, we felt that we need to add several things, not just people's knowledge, people's attitude, or people's behavior, or technology, or needs, or capacity, or system of information and institutions, but also laws and social values, and especially social values. So we look at palliative care. We have to, when we talk about palliative care, we have to bear in mind what kind of social ecology of healthcare is like, and that was the idea of this. So when we look at this, we realize when we examine the social ecology of healthcare, we realize that there is a term called patient solidarity. If you use that in Chinese, we call it 病友互助. But when we translate it, 病友 is very, very uniquely Chinese concept. That means friends in sickness, instead of what we see in the English literature talking about patient solidarity. So these are quite a little bit different, because when you call someone, a friend in sickness, that means the illness itself is the foundation of a friendship. So it's quite different from patient solidarity. But however, in my presentation today, I use a more familiar term called patient solidarity to refer to some qigong group and people using social media to help each other, and families join together for children, to help children with suffering from blood diseases, and there are actually seasonal communities formed among patients who group together, who become united by migrating from a cold place like Northeast China, Northwest China, to go to Southwest China and settle down there in the community for 6 months. Essentially, they become a migratory communities because of that, where they want to seek to rest and to recuperate. And we might call these places as offering therapeutic landscapes or environments. So there are many ways of people doing what they call the solidarity among friends in sickness. And there are 34 groups, people suffering from rare diseases, who have formed themselves trying to get medications from the United States mostly, and from Japan. But above that, they have formed themselves to create national banks, data banks for rare diseases, and join clinical trials. So these are very, very interesting development. But I see this as a critique of the social ecology of healthcare in China today. And the social ecology, when we talk about social ecology of healthcare, we have to talk about medical feminism. And I was just writing about people using connections to gain access to care. And this is very, very interesting, because there is a yearbook called Survey of Chinese Family Finance. And it has published for about 12 years. Every year there is a yearbook. And I asked my students to look at the yearbook, to look at one particular set of questions. And the question has to do with, did you use personal connections to have things done? So the questions, there were 5 questions. And the top one is, did you use personal connections to get your children into school? The second one, did you use personal connections ever? Have you ever to get medical treatment, or for treatment for other people? And then the third one was also very, very interesting, finding jobs. And then the number 4 was interesting. It was about legal assistance, and in gaining access to legal assistance, one has to use one's personal connections. And I kind of forgot the last one, but it's interesting that the people who designed the questionnaire identified 5 areas of needs where people mostly need to use personal connections to get things done. And it's very interesting. It's a national survey that includes very young and very old and very healthy and very sick people. So it's a mixed bag. About 10% of the people replied, yes, they have used personal connections to gain access. So we look at several other studies and focusing on patient groups and families and patient families instead of just a general population. And the figure of using personal connections to get access to medical care increased to 45%. And interestingly, in one small study, 175 doctors, medical doctors were interviewed, and more than 70% of them said, yes, they favor this kind of practice. And when they were asked why, and they said, personal connections, when patients were recommended to them, referred to them through a personal connection, it helps them to build their own personal network. So that's very interesting. And the second, what I call social ecology, and medical feminism, is inpatient. They call it inpatient companionship. It's a very confusing word, but however, in Chinese, it's very, very easy to understand. It's called 陪住. 陪住 means you become a companion by living in the same ward, in the hospital with your family member. And it's actually prohibited. The policy, the healthcare policies, they discourage this kind of practice. But people always use personal connections to get it done. And for instance, 2 years ago, when my mother was in the hospital, we find personal connections for my sister and I to rotate and sleep in her room every day. So she will have a family member in the room 24 hours, in addition to the attendance by the doctors and nurses. So that's what. And the third thing is about concealment of bad news controlled by family members. And this is very interesting to look at Chinese doctors' response. And you ask them, do you want to tell your patients about the bad news? And they said, and one survey said, one study in Shandong among 180 cancer doctors said, about 70% of them said, the first person I will tell is not the patient. It will be always the family members. That's the response. And once you tell the family members, the tendency is not to tell at all. And that leads to family-centered decisions. So when we look at our interview materials, we realize that not to tell concealment of medical information is, in many, many cases, related to people's sense of filial piety. So when we interview people and say, why you did not tell your father that, he's suffering from certain diseases at its terminal stage, and it's called about, and it's described as filial piety. So the idea behind this is that if we tell a patient about his or her terminal stage, the shock will be too much that the person would die. And the term for concealment in Chinese is man. It's actually talking about not to tell at all, of finding excuses. So that leads to some implications for awareness of dying. In 1960, in the early 1960s, Barney Glaser and Strauss and 2 other researchers did a study of 6 hospitals in the Los Angeles area, and they came up with a book called Awareness of Dying. It's very interesting to look at their findings. And their findings, they describe the situations of awareness of dying. The first type they identified they were called close awareness of dying. And the second is not gruesome, is guessing, is people guessed that they were about to die. And the third one is mutual pretense. In other words, a doctor knows and the patient knows, but they pretend that they don't know. And the last one they find was a rare practice, that is open one. But their conclusion was that this kind of awareness of dying was determined by hospitals and doctors in the American context. So when we read this book, and we said, oh, interesting word, interesting term, awareness of dying. So we look at our research material, especially our interview material. We realize that actually doctors have very little to do with concealment of the medical information, and because essentially it's the family that is in control, controlling the concealment, in control of telling half-truths, white lies, and in controlling intergenerational dynamics. Because it's very interesting, this time when we did this interview, we included a lot of young people. And many of these young people wonder why they can't tell. He said, and they use themselves as an example. They said, if I'm dying, I want to know. So why should my grandfather prohibit it from knowing? So the parents, the middle-aged parents, have to control the next generation from telling. And that's very interesting as well. The last one is, this part, the first part, 4 parts today, is about the ecology of palliative care. So when we ask ourselves why we started to offer palliative care to people, I mean, the fundamental reason, how did it start? So I look at the leading figure in pushing for palliative care among politicians. So the politician who did that was the party secretary of Shanghai. In 2012, he received an online open letter criticizing him, and it was written by a school teacher, by a high school teacher by the name of Qin Lin. And she criticized the city of Shanghai for shutting out her father, who was 78 years old and suffering from cancer. No hospital would admit him, and telling him that it's too late to come to a hospital. So she was struggling. So she published this letter. And at that time, the Shanghai party secretary was Yu Zhensheng, very interesting person. He immediately, the second day, he responded by writing a letter, an open letter, apologizing to Qinling, and also vowed to build a palliative care services in Shanghai. So you can see, after his response was publicized online, a week later, the Shanghai Health Bureau announced plans to set up a citywide palliative care services. So a politician, a political leader, really can make a difference. And 10 years later, we see Shanghai outpatients access. There were 82 hospitals offering outpatient access to palliative care. In other words, diagnosis, advices, and there were 118 facilities in Shanghai that actually offer inpatient access. So this is very, very interesting. But the rejection of late-stage patients remains. So last year, I did a search in the archive at my university called Science of Wisdom Archive. And a search for rejection of patients find over 3 million media reports within 1 year. So there was still a lot of rejections of patients. And I called it an additional feature of social ecology of healthcare. And Eric and I have been very, very interested in end of life at home, because you go to, we already said 80% of Chinese eventually die at home. And in the last few days, they still need care. But the most challenging problem for cancer patients to die at home is that they must go to a hospital to receive injections of pain-relieving medications. So oral painkillers can be taken home. They can be taken home, but they are not, the kind of the kind of oral painkillers we have are not very effective. The injectionable ones are very good. So they have to go to a hospital. So when some people most people in cities can still manage to go to a hospital, even in the last few days when they are extremely painful. But for people who are far away, like in the rural areas, they simply cannot go. So this is, Erica and I have been talking about how do we do this? Behind this is a fear that people will use painkillers as to abuse substance. In other words, it's like heroin, it's like crack, it's like any illicit drugs. And when we had a long history with opium problems before 1949, and the government does not want this problem to come back via painkillers. So this is what we have, the situation we have here. So when a lot of people who die at home and they do not have very effective painkillers, and they talk about ordeals, and they talk about pain because of illness, and pain because of not knowing, and anger because of pain and suffering, and some people admit they are already accustomed, they are already used to ordeals. And so these are the 23 narratives they were talking about. About 折磨, the very term we use is called ordeal. And we also have among the 19 people who actually died home of cancer, 10 of the people who talk about suicide. One of the families talk about suicide of the patient. One of them actually commits suicide successfully. And this is a case when doctors told him that he had no cure, there is no cure, and he should go home. It was so painful that in the middle of the night, he dreamed that his late brother was calling him from a top of a mountain. So he climbed off his bed, and he climbed to the mountain and jumped. It failed. He was caught by a pine tree on the slope. So he climbed back home And he said, I tried to commit suicide and I failed. And people were very shocked. The family was very shocked and trying to come. A few days later, it disappeared again. He said, it's too painful for me, too painful, liver cancer, too painful for me. I can't handle it. So he disappeared. So the family called, and this is a narrative provided by his grandson, who was a college student 2 years ago. And he wrote this narrative. We interviewed him and we wrote up the narrative with his help. He was called to go back home 100 miles to look for his grandfather. They looked and looked, and eventually they find his grandfather in the attic on top of a pile of corn. And he already used paper cuts, slit his waist and his ankles, and bled it to death. And there is a note that says, it was too painful. I wanted to live with you, but it's too painful. So, and the pain, as Arthur Kleinman was said, is a social suffering. It's not just physical pain. So when we interviewed people about pain, how do they describe pain? It's very interesting that they talk about economic pain first and frequently. The economic pain and the physical pain of the patients, the top two. Economic pain, why economic pain? Why economic suffering? And we look at our survey, what is being defined by the WHO as catastrophic health expenditure? That means one person's health expenditure occupies about 40% of one family's annual income. 94% of the people we surveyed said they suffer from catastrophic health expenditure for treating their cancer patients. So, and mental pain is actually less frequently discussed. And the bereavement of the family members of people who survived the death is also very, very, much less frequently discussed. So in other words, economic suffering and physical suffering maybe are easy to describe, while mental pain and bereavement is so difficult to articulate. But they must be there. They must be there. So we come to the second part of today's discussion, and that is meaningful death possible, or does good death make death meaningful? So I started by determining the terms. The old terms for good death would be ending well as having proper funerals and burials, ending well as dying well, still in glory. I suppose, the opposite, the very exact opposite would be violent death, all includes 9 forms of miserable way of dying. That's both, colloquial and Buddhist. And then we come with the very new idea that imported from the United States, dying with dignity, and the very old idea from China, enlightened death. So let's look at, the nuances of dying with dignity and enlightened death in the following. So let's look at good death. The very concept of good death expresses itself through living well in China. So we have a Living Well Association set up in 2006. And the manual for that organization was borrowed from a US Aging with Dignity NGO based in Florida. Essentially, we translated their text. Is called Aging with Dignity. Did not, but if you look at the second page, it's actually called Living Well. And then another stir created in China is the book called Being Mortal. But when it was translated into Chinese, they changed its title. They kept the English title, but the Chinese title is Best Goodbye. So our question when we were doing this, I mean, the first one is, according to Living Well, the US version of the Living Well, the leading question is, who makes decisions about my death? And then talking about dignity, we raised the question of dignity for whom? In addition to the dying person, does it include other people? And good death for whom? And what is best goodbye? So these are the questions we asked as we went along in the last 5 years. Living Well, very interesting. There are two versions now. There are two versions of Living Well in China now. One is social and culturally nuanced, and the other is legalistic. The legalistic one is very interesting. Actually, the Florida-based Aging with Dignity Living Well is more social and more culture. And the Chinese invented one is more legalistic and written by a group of Chinese medical legal scholars. And essentially, the second version, the more legalistic person, essentially asked for 6 rejections. And the American one, or the Chinese one, we adapted it from Florida, is about 5 wishes. So 6 rejections. In other words, what you need. Do you need a respiratory? Do you need feeding tube? Do you need antibiotics? Do you need other invasive treatments? Essentially, it's about, do you reject this? And the problem with this is once we take a legal rational approach to palliative care, it creates a problem in experiment. In other words, in reality. And this is what I want to talk about. The only city in China that actually legalized living well, legal is the city of Shenzhen. 2 years ago, they legalized it. Essentially, their idea was, once people sign a living will, the doctors can override the family caregivers. In other words, we can save resources, we can save time, and we can save time for talking with families, because the patient already signed a living will. So we just use the document to make our decisions. It has been implemented for 2 years. 55 people signed living will in 2 years. It simply did not work. So when the Living Will Association, the head of Living Will Association in Shenzhen came to us, to my university, and joined the conference. And we started to explore other options. And eventually we used an Australian advanced care planning manual, and we look at this manual, and we talk with about 12 Chinese doctors and say, how can we use a manual for advanced care planning from Australia? And they said, let's look at Taiwan, Singapore, and Hong Kong, who have been doing palliative care in the last 20 years. So we look at them, add it together, and put this Chinese adaptation of advanced care planning for Shenzhen to use. And I almost can say that this year there will be at least 5 times more, the number of people who are signing this will be 5-10 times more than this. Because essentially advanced care planning that the manual we designed was about conversation, not about the legal responsibilities. It's really to encourage doctors, families, and the patient to talk and to record this conversation as a document, for the doctors as a reference. Why Shenzhen failed? It's very interesting because when we did our cancer patient survey, we find about 30% of the cancer patients made their own decisions, while the other patients had their spouses and their adult children as the primary decision makers. And fewer than 4% of these patients rely on other people. So if we look at even closer, actually spouses are not very important. Children are most important in making these decisions. And when children make these decisions, adult children make these decisions, and the decisions are most likely for the patients to receive intensive treatment. So apparently, filial piety has a great impact on critical decisions in clinical settings. And in order to conceptualize this situation, we looked for inspirations. And one of the inspiration that came to me was a friend of mine who did this photo about a dying child in Shanxi. It's a realistic photo. It's a real photo. And the child was dying in a traditional Chinese hospital, Chinese medicine hospital. I can see the father was looking at the cameraman, and the mother sits next to the baby, and the mother's sister opposite the mother, and in the corner is the grandfather. So when I look at this, and dying apparently is not an individual act, and it is relational. The self is relational, and the decisions are relational, and the situations are relational. So this is one of the inspirations we had. We look at this, we asked Qu Yan why he took the picture. And he bluntly said, it's actually not the child that caught my attention. It's the adults. It's what the adults were doing that caught his attention. So this is one of the sources of inspiration for us. So when it comes to decisions, and the information obtained from family gamers shows 30% of this, they make their decisions. So what I'm saying, I borrowed the term from Eric called DMT, disease modifying treatment. I mean, we don't even know how to describe this anymore. So we use a very, very complicated word for intensive treatment. So essentially, children make decisions, and their decisions are pro-intensive treatment. So I would like to quote a statement from Sima Qian. When people are bound to die, some die as light as a feather, while others die as great as the Mount Tai. It's very interesting, Sima Qian. But in Sima Qian's, the records of the grand historian, he recorded 2,000 cases of deaths in his book, how people died. And in conclusion, he wrote several statements. And the second statement, similar statement, is only after the day of death will right and wrong at last be determined. So if we read, the records of the grand historian, we realize that cases, there are about 5,000 cases of people he wrote about, biographies, short biographies, but 2,000 of them, around 2,000 of them, dealt with how people died. This is very interesting to us. So we read this, and we also consulted, because I knew a group of Buddhist monks, and I started to realize that it's very interesting to look at terminologies for us, because of 10 years ago, I worked on blood donation. So I borrowed Richard Titmont's idea called gift of life. But he could have used the Buddhist concept of life-giving to enrich his work instead of theorizing gift of life in reference to Marcel Mauss, anthropologists. And the Buddhist story about gift of life is expressed in two stories. Two stories. One is about a person, three brothers, who traveled into mountains and saw three hungry tiger cubs and the hungry mother. And the mother was about to eat her children. So the youngest brother stepped forward and offered himself as food for the mother. And the second story is really about reincarnation, a saint in reincarnation. In one of the stage, the heavenly king, in order to test him, transformed himself into a hawk and a pigeon, and the hawk was chasing the pigeon. So when this saint saw this, he offered himself as food to the hawk in order to save the pigeon. So the Buddhist expression of this is called 以身布施, giving life. So, and I realized that actually the coinage of Gift of Life by Richard Titmuss was very old, actually, very, very old, rooted in Buddhist concept of giving life. And the Buddhist concept is also talks about knowing the approach of dice, 一知生死, and knowing the minds of others. And why these two concepts are very important for our research is because in the Pure Land sect of Buddhism, there is a tradition called reverse care. Reverse. In other words, a person is dying, but his mentor would say, stop crying. Stop feeling sorry for yourself. Think about the millions and millions of people who are suffering and what you can do for them. So the idea about this is actually developed, or has actually developed into many phrases within the Pure Land sect. In other words, how do you deal with a person about to die, who is about to die? Do you just only offer comfort without awakening, without arousing the person to think about other people? And this is what we were talking about, relational death, relational self. Let me provide some examples. In the Republican period of China, in other words, from 1911 to 1949, there were a lot of, newspaper articles about enlightened death, and one of them deals with the death of a monk in Hangzhou, in Suzhou. So before he was about to die, he called two of his disciples to his room and said to one disciple, said, since you came to me, you are my most favorite. You are my best students. But however, I don't think you should be the leader of this monastery. Is this guy who is not my favorite, who has the leadership capacity and skills. So I want you to settle your differences and be united. When I die, our monastery can continue as one unit. So the two disciples said to him, yes, and this. So he was choosing a date, and he helped these two disciples to assume leadership. His favorite student was in the second place. And after preparing everything, he said, I cannot die when things are not taken care of before I go. So this was published, in the newspaper, talking about this famous monk and how he went away. On the last day, he realized he was about to die. He went to the toilet, the bathroom, and cleaned himself without bothering his disciples. I mean, he actually cleaned himself. He said, I want to clean myself for the last time. And he sat on the chair and died in prayers. And 10 years ago, a university professor, young professor called Yu Juan, was diagnosed with breast cancer. And she was desperate. She was despondent. But the one thing she decided in the last year of her life was to write cancer diaries, to educate Chinese young women about cancer, about breast cancer. It attracted 10 million readers. And when Shi Tiesheng, a writer in Tianjin, died, he wrote a very long piece about why he was willing to donate his katiba and his organs. So this is very, very interesting. And a friend of mine, a Japanese scholar, now working in Stanford, Akura Suzuki, wrote about the Japanese while alive funerals. And this is also very touching because one of the stories is concerned with a Japanese businessman who made a huge fortune by establishing a Japanese shopping mall in Shanghai. And then he established several shopping malls throughout Southeast Asia. And all the shopping malls were ruined during the year 2008 Asian financial crisis. So before he died, he called upon his Japanese colleagues and the former employees he fired, he laid off, and said, this is my funeral today. And during this funeral, I want to apologize to everyone for my mismanagement of these shopping malls that led to your unemployment. And the last thing I want to say is about the environmental friendly green burials. The Chinese government is against, whole body burial. Of course, for many years, only Muslims can do it. The other people have to cremate them. But once we cremate our bodies, what else do we create? We create a stone tablet, a huge one, 0.5 meter wide. And we occupy 1 meter of land to put our ashes in. So if we go to northwest China, northwest Beijing, near the Ming tombs, there are 13 tombs belonging to the emperors of Ming Dynasty. And outside the imperial graveyards, there are hundreds and hundreds of graveyards. And there are thousands and thousands of headstones, huge headstones. And there is a movement now in China called environmental burial. And that means seed burial, tree burial, and flower burial. And in other words, you have a garden burial. And this is encouraged by the Chinese government. And the people who followed it most enthusiastically turned out to be Buddhists. And they preferred seed burials. Now, along the coast, the services for seed burials are almost entirely Buddhist in China. And the last issue I want to take up is a matter of concern. I know Eric is very enthusiastic about promoting palliative care in China. And we are going to publish his manual on palliative care. And he's very interested in training Chinese doctors, Chinese physicians to practice palliative care. But this is a concern I'm going to share with you, Eric. And I call it unintended consequence. So I still have a little bit time, I think. And being a scholar, so we all want references. So I'm going to talk about a few references before I got into my concern. Lao Tzu, a Chinese philosopher, actually once developed a brilliant idea about unintended consequence. Essentially, he was sitting under a tree together with his students, and it was the only tree on top of a mountain, and the entire mountain was treeless. So his students was talking. His students were saying, "This old tree is really useless because the timber is too soft. It's too soft." And Lao Tzu raised his head and said, "Oh yes, very, very useless, but still provides shade for us. And it's 100 years old." And he pointed to the slope and said, "You know, in the past, the entire mountain was covered with trees. The trees that were as hard as iron were cut down for making weapons because the farmers heard that in the market there is a very, very good price for this hardwood. And they were willing even to sell the seeds for this. So the trees as hard as iron are gone from this mountain. And then they started to build, to grow trees that are hard as a stone. And then when the farmers heard there is a very, very good price, unusually good price, they cut down those trees. They were only able to grow fruit trees. And they cultivated the fruit trees by protecting them excessively, giving them manure and picking bugs and worms from the tree. The trees were so spoiled that when the new disease came, brought by a new bug, they all also died. So we end up with an old, useless tree. So I think when I read this and I said, wow, this is very, very interesting, because it fits the description by Frederick Bastiat, a French philosopher and a politician, who talk about that which is seen and that is which unseen. And of course, Marx, Engels, Robert Merton, and Arthur Kleinman all talked about unintended consequence, especially Arthur talked about unintended consequence as a theory for global health. And so bearing those references in mind, I will suggest that palliative care in China today is increasingly being handled as terminal care. And it is beginning to be seen as solely for the elderly. And a few very large corporations in the funeral industry already package palliative care with funeral services. So my worry is this. It could become a cost-cutting measure for neoliberalism. In other words, hospitals need to cut expenses. So we don't want to offer people proactive and invasive care anymore if we determine they don't need it. So we cut. We don't give them those treatments. We shift them to palliative care units. It could be a cost-cutting measure. And actually, a lot of people are talking about that. And then the worry becomes real, that palliative care units could become like morgues. And this is what I actually saw in Shenzhen. One hospital was designated by the city government as the concentration hospital for the dying. The other hospitals all send their dying patients to this particular one. And when I entered this hospital, I must say, I refused to go in. I start to smell death as soon as I entered this hospital. The smell was so terrifying. And I said, I'm not going in. I can't go in. But there are also good ones, high-end UWS hotel-like facilities for the rich and powerful. And if you go to the 301 military hospital, the east wing of the hospital, it was hotel-like. So I'm concerned about this unintended consequence of promoting palliative care in China. And the last slide is especially to be shared with Eric. Eric, thank you. I end here.
Wow, thank you. Thank you so much, Jun Laoshi, Professor Jing Jun. This is very powerful, and there's so much to unpack here. And I feel, of course, very inadequate at even beginning the discussion, because I don't speak Chinese and I don't read it and I don't know all these traditions. But I'm married to China. I'm married to, my wife is Chinese, and from working also in Vietnam for many years, and seeing how extremely important filial piety seems to be in decision making. I wonder about a few things about filial piety. First, I wonder about the relationship between filial piety and the Chinese, and pardon my accent, I think Shaoshuan is what I mean by filial piety. The relationship between filial piety and another one of the terms. Could you turn back the slide to about the third or fourth slide, which had translations of a lot of important terms? A little more. I think it was maybe one more. Yeah.
Which one?
The one with yeah, this one.
Yeah.
So that term proper death, I was actually asked by a high official to help reinterpret Shanzhong, proper death, in the modern age. And as we've discussed, Professor Jun, one of my big concerns that I see in China is that family members, because of the feeling of filial piety, which, as we know, is an ancient value that predates even Confucius, Kongzi. It even predates the Confucian philosophy, although filial piety is a very important part of that. Because of that, the importance of filial piety, family members, especially children, adult children, feel obligated to demand all life-sustaining treatments for their elders, including when their parents or grandparents are very near death, very sick. They may have metastatic cancer or end-stage organ failure, but they feel obligated. And if they don't demand intensive life-sustaining treatment, they are sometimes regarded by their siblings and other family members as non-filial children, which is a terrible thing to be accused of, as bad children. So is it possible to reinterpret filial piety in the age of invasive life-sustaining treatments like cardiopulmonary resuscitation, mechanical ventilation, ECMO, extracorporeal membrane oxygenation, all of these invasive treatments, hemodialysis? Is it possible that filial piety with a kind of a public debate could be reinterpreted so that in certain situations, adult children could feel proud that they take the best care of their elders by protecting them from a violent death, a non-comfortable death in an intensive care unit, or a death in the midst of CPR, or suffering the effects of chemotherapy at the very end stage. Is that sort of rethinking, reinterpretation of filial piety a possibility? And this also gets back to this question about how do you interpret, or what is a proper death? Shanzhong. What does that mean? And that will also then influence, of course, what is palliative care? What should palliative care focus on? Should it be comfort? Should it be harmony? We see that one of the translations here for palliative medicine, the second line from the bottom is 还和医疗, so striving for comfort and harmony. Should it be enlightenment? And then lastly, how, and this is based on your final slide, how can we protect against the marketing, as it were, of palliative care and the transformation of palliative care into a way to save money, and to not have to express filial piety? Can filial piety be reinterpreted but still be a protection against this, as you say, neoliberal threat of regarding old people as just as not as valuable, not worth spending a lot of money on? So there's many questions there, but please.
Eric, there are two questions. The first question is about filial piety, and you think filial piety is the way of promoting palliative care, and that is your assumption, right? And I tend to disagree in the sense. The key here is not because they are so filial, they are trying so hard, and they are putting their parents and the older people through ordeal. I think the key here is about lacking information, lacking guidance. I really put the blame on the medical community rather than on the families. The families do so, but the medical community help the family to intensify the sense of, because they don't give them proper information. And so the conversation, there is lack of conversation. And I think when people really understand the nuances of the situation, about the prognosis, they'll come, most of them, I would say, come to the right conclusion. Filial piety is not in the way of palliative care. It's the medical community's old habit that in the way of palliative care in China. When you do not communicate, or you do not know how to communicate with the family, and the family only assumes that there is still hope. So this is what to go back to your first question. Yes, it plays a fundamental, it works as a fundamental factor in people's decisions. But if we scratch the surface and asking why they make such decisions, is it really just because of palliative care? Filial piety? My answer is yes, it plays a role. But fundamentally, they don't have the right information. So the second one, I'm blunt, I'm being very blunt, Eric. And the second one is about commercialization of this. And it's not so much commercialization, but rather about cutting costs. I mean, saving money. Palliative care is pushed towards the direction of money saving, the economics of healthcare. And I think policymakers may care about money saving, probably even more than relieving suffering. Because the money saving is their job. I mean, I don't know whether relieving people's suffering is part of their job description. I'm sorry to say that. So the second part is, I mean, Eric, you are going to work with Chinese doctors and Chinese top-notch doctors. I'm almost afraid that they will eventually describe as specialists in death and dying. They're not doctors anymore.
Thank you. That's so. This is very interesting to me that the problem that it's really the doctors who need to understand that they need to explain the situation well enough, and that if it's explained well enough, the family members will know how to express their filial piety. So this would be a very different focus, and in some way, I think it'd be well, I'm not sure if it's an easier task to try to educate the healthcare providers.
But Eric, it would be even harder to change people's sense of filial piety.
Yeah.
I mean, say you have to be filial by relieving pain from your parents. But at the same time, they would say, then we stop all the treatment, and that's the end of suffering. And then we need the right information. When do we stop?
Well,
So this is why I say doctors play a major role, and in making these decisions.
I just came from a family meeting with a patient here in the hospital. Mm-hmm. And one of the key issues was, what is the baseline quality of life? Is this a quality of life that's acceptable for the patient? And if the baseline quality of life was, the patient was feeling not very happy with how their quality of life. And then they had a complication and were in the hospital, and they'll never make it back even to their previous quality of life. So mm-hmm. in that case, should we protect the patient from going through any life-sustaining treatment? So the problem that I've encountered, and even within my own family or my relatives in China, is that the idea, just the concept of quality of life, or a quality of life that's not okay. Maybe the patients would not want to admit that their quality of life is not acceptable because that wouldn't be a proper thing to say, or the children would never want to say that I don't think my mom's quality of life is acceptable, therefore I don't want her intubated, I don't want her to go to the intensive care unit. Does this concept of quality of life, is that translatable? Because that's a key part of our decision making about how to take care of people at the end of life in the West.
Mm-hmm. Eric, there are some very interesting questions. Stephen Connor asked, when treatments become non-beneficial. I mean, it's not a question for me. It's a question probably for all of us, because that's really, really difficult to say. What is the boundary of non-beneficial? And this is why I like the book written by an American anthropologist called A Time to Die. And essentially, she came to the conclusion that the chaos theory is the best theory to be applied to decisions, for critical decisions. And we don't really know what decisions would be best. Sometimes we think we make the best decision, and then we end up regretting it. And sometimes we thought we made a bad decision and turned out to be good. So I like her book. It's called A Time to Die. It's really talking about uncertainty about this diagnosis and prognosis, and uncertainty, and the uncertainty also. I mean, And then it certainly makes doctors nervous about communication. So the Chinese doctors do not want to be held to legal responsibilities in prognosis conversations. So Eric, what do you do? I mean, that's my question. I mean, from a clinical point of view, how long did you have this conference? I mean, you said you just had a family meeting. How long did it last?
Well, family meetings could last a few minutes or hours without conclusion. It varies a lot, but you know, in general, I try just to get to know patients as well as I can, both their values, what's meaningful in their life, what what makes their life, the quality of life acceptable, what are their joys, their sorrows, and then the clinical situation in detail, including the prognosis. And then based on that data, I make a suggestion. But, you know, in various cultures, you know, in some cultures, there's this idea that every second of life is sacred and valuable and must be striven for by all means. Or saving one person's life is like saving the whole world. And so, you know, figuring out how to provide palliative care not only is a question of contextualization to the culture, but it's also an individual. And just because a patient is Chinese or American or Rwandan, we shouldn't assume anything.
No.
But I still I wonder about contextualization for China. We know filial piety is very important, and we had this long discussion about how to translate the term palliative care into Chinese with the various different translations from various from Taiwan, from Hong Kong, from Singapore. So one of the things that I hope to be working with you on going into the future is what tend to be important values throughout China. Is it harmony? Is it comfort? Enlightenment, as you've described it? And how can palliative care services and teams be structured to help patients achieve those important, meaningful goals?
Eric, this is what my response, and to achieve this, you know, to be culturally sensitive, cultural sensitivity is very important for us to consider, you know, the contextualization of the practice. But my argument would be, we have to have the basics. The basics, you have to have the basic drugs. And then you have to have the basic requirement for family conversations. And you have to have some basics for consultation with the patient and through the family. Otherwise, if the doctors, I mean, this is the problem as I see in the Chinese medical community, they don't communicate. So they rely on the communicate even with the families. They have say a few words and they walked away. And they say, I can't help you to make any decisions. I tell you the truth, and then you make the decisions. I mean, my question is, the decision-making should be the decision-making of a medical doctor in palliative care units, part of the decision, or the decision should be entirely the family. So Eric, let me address, because I want to address other people's questions. And there is a question, do patients dying at home have access to same pain management than palliative care patients? Of course not at all, not at all. Especially if you live in rural areas, you go without even simple painkillers, because the painkillers are terribly afraid by the Chinese government to be in danger of becoming illicit drugs. And they just don't, even in Shanghai, they don't give patients the same pain management. And there are two more questions. What is the status of offering legal euthanasia in palliative care? There's no, merciful treatment of patients. No, you can't do it. You can stop treatment. That's about it. And status of use in the drugs, in pain control drugs in palliative. Yeah, this is actually starting to be very, very developed, in the sense that Chinese doctors are actually talking about using new drugs that you can use through the nose, you can orally, that can be much more powerful and effective than the old drugs. And this is very much, this technique is very, very much discussed, and a lot of well-run hospitals allow much greater dosages of pain control drugs for the patients. That's very encouraging, actually. And Connor came back and said, about the boundary, non-beneficial boundary. Connor believed that it's burden and benefits question. I think it's very interesting. But benefits we already talked about. What is the burden? And I would like to Connor to say, what do you mean by burden that comes to the decision? Burden for several people, burden for the doctor, burden for the family, as health takers, the nurses, and the burden for the dying patients as well. So that, in other words, I still insist that when we come to decisions, Eric, you're a medical doctor for so many years, and do we have a clear path in front of us to communicate with people, with families about dying? Or rather, we struggle with uncertainties? Eric, I'll leave the last question to you.
Well, thank you, Junlao Shi. My experience in China so far is very limited, but as you were talking, I was just remembering patients who I saw in Beijing, and where there were difficult decisions to be made. And I was invited to give my opinion, and based on as much knowledge as I had. And the conversations in those cases tended to go very well. This was a very unusual situation in that we took time, an hour or two, and sat and talked and let the family members cry and gave them time to ask questions. And I thought good decisions were being made. So it's really enlightening to me to think that the blockage, the insistence on aggressive life-sustaining treatment for dying patients is maybe more is more of a problem generated by doctors, and not and that family members would be receptive to the idea that they can express their filial piety without demanding life-sustaining treatment. So this is really helpful. In fact, I really would like at least one paper to come out of this talk. This is really so important. And these concepts that are shown on the slide right here, I think a lot more, I'd love to do a lot more with that. In fact, I think there's several papers that come out of this, which could maybe be part of the effort to educate doctors in China. And for me, it's not an education. To me, it's more a conversation, because we need to understand what pressures are on the doctors, and their values and their worries. But I think this is very important work. Absolutely, I agree with Stephen. It's really brilliant. And thank you so much. I know it's now 5 o'clock in the morning. And wish you Happy New Year. I look forward to seeing you in a few months. And let's please keep this conversation going.
Eric, in front of everyone, I want to say this. I haven't been to Harvard since 2005. So get a grant through the Radcliffe. We were talking about this. There is a workshop thing. I would like to visit you in Boston. Okay.
Please. Well, let's do that. Thank
Yeah,
you
let's
so
do them.
much,
Okay.
Junao Shi. Thanks
Okay.
to all who joined us.
Everyone,
a-
thank
and so-
everyone. Yeah.
Happy New Year and signing off from
Happy New Year.
Program in Global Palliative Care at Harvard Medical School.
Okay.
Thank you.
Thank you, everyone. Bye.
Bye-bye.
Thank you.